Ouça sons de ASMR com a tela desligada e relaxe sem interrupções. Teste o YouTube Premium grátis.
A epilepsia é uma experiência que tira o paciente do eixo, limitando atividades simples como dirigir, viajar sozinho ou até mesmo nadar. E o tratamento que era para ser um alívio, muitas vezes traz outros sofrimentos. E assim o paciente perde o controle da vida, ora temeroso que uma nova crise possa acontecer, ora refém de medicamentos que o limitam pelos efeitos indesejados. Lacos chegou para dar mais controle à vida dos pacientes. Pois lacosamida é tranquilidade de prescrição com boa tolerabilidade. É segurança do baixo perfil e interações medicamentosas para uma qualidade de vida melhor. Assim, sem provocar mais complicações, abraça vários perfis de pacientes. Lacos acredita que falar sobre qualidade de vida de um paciente com epilepsia é olhar além das crises epiléticas, é transformar o medo em liberdade, é entender que se quer viver com controle da própria vida, sem medos, sem complicações adicionais. Lacos, controle além das crises.
Boa noite a todos, é um prazer estar aqui com vocês hoje. Estamos hoje conectados em mais de 100 locais do Brasil inteiro, além de diversas pessoas remotas nos assistindo. E em nome da Libes, eu gostaria de agradecer a todos pela participação. Eu sou o César, responsável pelos produtos de epilepsia da Libes, e a gente vem hoje aqui trazer para vocês um debate super importante sobre essa molécula que é a lacosamida. Eu só gostaria de avisar a todos que, caso vocês queiram mudar o áudio tanto para inglês como para português, vocês podem, clicando no globo que está na tela aí de vocês no Zoom, tá bom? É só você clicar, selecionar inglês ou português, conforme vocês acharem mais confortável. Além disso, vocês podem ir mandando perguntas ao longo da apresentação dos doutores, que a gente vai responder essas perguntas, os doutores vão trazer isso para a discussão, e caso alguma pergunta não seja respondida hoje, a gente vai fazer questão de mandar isso em texto e responder para todos vocês, tá bom? Hoje eu estou aqui com o Dr. Vicente Villanueva, ele é neurologista no Serviço de Neurologia do Hospital La Fé, em Valência, membro da ILAI, e também professor associado de Neurologia da Universidade de Valência. Thank you for being here with us today, Dr. Villanueva. Também estou com o Dr. Luiz Betting, ele é professor adjunto do Departamento de Neurologia da Unesp de Botucatu, e também com o Dr. André Palmini, professor de Neurologia do Núcleo de Neurociências da PUC do Rio Grande do Sul. Obrigado a todos os doutores que estão aqui e agradeço a todos a participação de vocês nesse evento. Um bom evento a todos. A palavra agora está com você, doutor André.
Então tá. Boa noite, pessoal. A gente está aqui reunido nesse estúdio aqui em Perdizes, em São Paulo, e o doutor Villanueva está lá em Valência, na Espanha. Como a gente vai ver depois, o doutor Villanueva é uma das pessoas que mais pesquisou e mais entende, mais experiência tem com a lacosamida. Acho que a gente está com a ideia de fazer uma atividade que seja dinâmica e que realmente foi bolada assim, pensando no interesse e na necessidade de cada neurologista que trabalha com epilepsia. A gente procurou fazer uma coisa assim, ensaiar bem, pensar bem nas questões principais, naquilo que realmente angustia, às vezes, o neurologista na hora de escolher um medicamento para epilepsia. Então, assim, eu estou muito satisfeito de saber que tem bastante gente aí pelo Brasil hoje participando junto com a gente. Estou muito contente de poder interagir com o doutor Villanueva e também com o meu colega aqui, Luiz Betting. Luiz, dá boa noite para os nossos colegas aí.
Boa noite a todos. Gostaria de agradecer a Libes pelo convite. É um grande prazer estar aqui com dois brilhantes epileptologistas e discutir, falar um pouquinho sobre a lacosamida. Eu acho que esse formato que a gente selecionou vai ser bastante interessante, bastante proveitoso para todos. Muito obrigado.
Então, como é que vai funcionar? A gente mais ou menos selecionou 8 questões bem específicas, bem objetivas, que têm a ver com a forma de pensar o tratamento da epilepsia e especialmente a forma de usar a lacosamida, tá certo? Então a gente montou essa atividade assim, Eu vou colocar uma questão para o professor Villanueva, vou colocar essa questão em inglês, ele vai discorrer sobre essa questão, né, mesclando a experiência que ele tem com dados de literatura, muitos que ele mesmo produziu em estudos dele, e a partir daí a gente vai estabelecer um debate. Eu quero convidar vocês para participar desse debate. Não é? Vocês podem mandar pelo chat perguntas ao longo da apresentação, para que a gente possa também trazer as perguntas de vocês para o professor Villanueva e trazer para o nosso debate. Então, sem mais delongas, good evening, Vicente. Thank you very much for being with us. And the first question, Vicente, that we organize for you, knowing that you are an expert in lacosamide, but not only in lacosamide, but also in epilepsy, in epileptology in general. The question is, why do you think lacosamide should be considered by neurologists not as simply one more medication, one more medication in the armamentarium, but actually one very important addition to the armamentarium the neurologist has to treat epileptic seizures? Why do you think it's so important, this medication? We don't have sound?
Can you hear me?
Yes, now yes.
Okay, sorry, I was saying good night. It's nearly good morning in Spain because we have a few hours more. And thank you for inviting me to participate in this meeting. Thank you to Lips for inviting me. So I can't see my slides. It's possible to see them in my screen? Or not possible? Okay. So the reason I think lacosamide is a good medicine is the reason because any anti-seizure medication should be considered as a good medication. Okay, we have here. Next slide, please. Next slide, please. Next slide, please. Next slide, please. Okay, as I say, the reason I think we should consider lacosamide as a medication to treat our patients with epilepsy is at the same reason that we choose any medication. So we need to have a medication that was effective, had no side effects, and was good to combine and to treat patients that have other pathologies, that have other issues. Having all this in mind, why I started to use lacosamide at the beginning? First of all, the first thing that it looked my attention was that it has a different mechanism of action. It was a slow sodium channel blocker inactivator. Probably doesn't mean nothing, or we didn't know what it did mean at the beginning, but at the end, we observed that make a different possibility and a different option to use a sodium channel blocker, and how this was extrapolated in the studies. Next slide, please. Please, this is animated slide. Let's move forward and then go to the next one. So what we decided at the beginning was to, when any new anti-seizure medication is launched in any country, was to try how was this medication working in very difficult patients. And what we observed is that in a difficult to treat population, and we did this study in 500 patients, next slide, that we observed that we got patients seizure-free and the first stages of the treatment, as it would have happened probably with any other medication, but also when we have used up to 7, 8, or 9 medication, we still have the possibility to have seizure freedom. So the first thing that we needed to demonstrate to start in using a new medication that was effectiveness was achieved after this study. Next slide, please. And then we move our mind, as it happened with all the medication, and we started in the difficult cases, and we moved to the monotherapy or to easier cases. And for proving how this medication was working in the monotherapy, we also did this study in which we collected around 500 patients too. Next slide, please. And we observed that in the monotherapy patient, next slide, please. It was working in different options. In the full population, full monotherapy population, at the end of 1 year, we got this more than 50% of patients seizure-free, and was working regardless of the population. I mean, in patients that have tried a few medication before and were converted to monotherapy, or in patients that started monotherapy from scratch. And we observed that was effective in elderly patients, probably a little bit more effective because this epilepsy probably is not so difficult in this patient, but we needed to prove, and also in that were younger than 65 years. And this study was important because we were convinced that this drug will be useful in monotherapy. And why is particularly interesting this drug in monotherapy? Next slide, please. Because when we analyze the pharmacokinetic, we have observed that this drug have no interaction with any other medication. Next slide, please. And if we take a look of the number of interactions that we have seen with all this anti-seizure medication, this is one of the few medications that have zero interaction. So this is very, very important because when we start a medication in a patient, I'm always thinking, probably this patient is going to be treated for years, for maybe his entire life, and we need to use something that was not only effective, that have very few side effects, we will see probably later in this conversation. And it's very important that the drug that we are using was good to combine with other medication that probably the patient is going to be using in their life, like antibiotics or whatever, or chemotherapy or whatever, considering the life. Next slide, please. So to prove that, I think we consider that lacosamide was a good medication in monotherapy, and as in comorbidities, that is what I was trying to convey when we are talking about interaction. We did this study in Spain, and we asked a lot of neurologists in a Delphi study what will be the first option in monotherapy in different comorbidities, like cancer patient, like polymedicated patient, like patient with a psychiatric problem with neuropathic pain. And lacosamide was chosen as a first option. Not only lacosamide, in some of the indication was also combined with other possibilities, but in all of them was consider lacosamide as a good option, because we consider, and this is my humble opinion, that it's a very good drug for patients that have any type of monotherapy based off this PK profile with zero interaction. And last slide, next slide, please. This study was similar than in US. In this study by the American Academy of Neurology, that is a similar study, and after this publication, lacosamide was chosen as a good option in different type of comorbidity, like cognitive issues in the patient, neuropathic pain, or hepatic dysfunction, oncology patient, etc. So to finish and to summarize, I think lacosamide should be considered, first of all, because it's effective, difficult patient, monotherapy. Second, because, as we will see later, have few side effects. And in third place, because have zero interaction, is an excellent option in patient with comorbidity to avoid interaction.
Thank you. Eu acho assim, talvez só a maneira como eu entendi e interpretei essa literatura e a colocação do professor Villanueva é que a gente está diante de uma medicação que tem várias vantagens em relação, inclusive, a outros medicamentos da mesma classe. Eu acho que isso é uma coisa muito importante, porque comparado com outros bloqueadores de canal de sódio, por exemplo, que se usa para crises focais, a lacosamida tem menos efeitos colaterais. A gente vai ver depois que ela é mais fácil de titular, ela tem um perfil farmacocinético melhor e ela é bastante eficaz. Mas tem um aspecto que eu pedi que o Luiz comente, eu acho que todo mundo tem que, não sei se prestaram atenção, mas tem 2 ou 3 diapositivos relativos a alguns estudos que mostram que a eficácia ela é maior quando a lacosamida é usado mais precocemente e não depois de tantas outras tentativas. Isso está de acordo com o que se vê hoje, e se conhece na literatura, que a quantidade de crises que um paciente tem antes, né, ao longo da sua vida, vai dificultando mais, vai tornando mais difícil o controle dessas crises. Então, Luiz, como é que tu vê esse assunto do posicionamento de um medicamento em relação à ordem de medicamentos, já que quanto mais cedo tu inicia num paciente, menos crise ele vai ter tido até usar aquele medicamento. Ou seja, como é que tu vê isso?
Eu acho que ao selecionar uma medicação anticrise, a gente tem que considerar sempre e tentar equilibrar aquela balança entre o efeito adverso e a presença e a frequência de crises epilépticas. E muitas vezes nós não temos margens para erros. Precisamos selecionar a melhor medicação e, claro, utilizar ela na melhor dose possível para que as crises já sejam controladas desde o início. Cabe lembrar que para fazer essa seleção, precisamos usar as melhores evidências disponíveis, que para a lacosamida são justamente essas que nós estamos revendo aqui hoje. Essas são as evidências que mostram que a lacosamida é eficaz em monoterapia e em politerapia. Isso é bastante importante lembrar. Portanto, o Dr. Vicente acabou de colocar que é uma das primeiras opções, medicação de primeira linha, na opinião dele. Vale lembrar também que para selecionar a medicação, precisamos considerar o tipo de crise e o tipo de epilepsia. E aqui, mais uma vez, lacosamida para as epilepsias focais, então é uma primeira linha. Segunda coisa é considerar o perfil do remédio, e acabamos de ver isso também, que a farmacocinética, ou seja, a forma que a medicação é absorvida, distribuída, e a baixa interação medicamentosa faz dela uma medicação bastante interessante. E, finalmente, considerar características individuais, que foi esse último slide que nós vimos.
Perfeito. Então, assim, acho que um resumo interessante é assim, a lacosamida ela é um remédio que tem esse perfil muito favorável e vai ser mais favorável ainda quanto mais precocemente se iniciar no tratamento do paciente. Vicente, we have been discussing, I mean, your approach to why lacosamide is such an important drug. The next question, I mean, Luis raised the issue that lacosamide can be used both for focal and generalized seizures. And also, but this will be discussed later, but also either in monotherapy or polytherapy. So now let me ask you a question regarding monotherapy. So let's now focus monotherapy. Let's see, you decided to start with lacosamide. In Brazil, and I think in Spain as well, in other parts of the world, we have 4 presentations of pills, 50 milligrams, 100 milligrams, 150, and 200. As we know, we want to achieve protection against seizures as soon as possible. So we want to achieve a level of anti-seizure medication as soon as possible so that we can protect the patient as soon as possible. So it's important now to discuss about titration. How would you suggest lacosamide should be titrated in monotherapy so that we can diminish the risk of seizures, at the same time not incurring into many side effects, you see? So how do you make this balance between not so fast that you have adverse events, not so slow that you titrate in a way that people will have seizures as you titrate? So how do you do this?
Okay, thank you. Next slide, please. Next slide. Okay, in monotherapy, as you mentioned, there are basically 2 things, two ways to do it. One way, and I do this for many patients, is starting with in my opinion, therapeutic dose in most of the monotherapy patients, 200 milligrams first day, 100 in the morning, 100 at night. If we consider that this patient, for whatever reason, could be sensitive to side effects, then I start 100 milligrams first day, and I increase up the dosage to 200. That, as I say, I think is enough to get protection in many monotherapy patients in 1 week. So these are the two options depending on the type of patient. We start this drug very frequently in the emergency service, and we start for those patients that we need a rapid protection because they have attended the emergency service because they had a breakthrough seizure or whatever, directly the first day with 200 milligrams, 100 in the morning, 100 at night. But if we have the time, then we can move a little bit slowly. Next slide, please. For other, if we consider other scenarios different than monotherapy, then probably we need higher dosage, and we need 400 milligrams and even a little bit higher for some patients on adjunctive therapy in more refractory cases. In this case, after the 100, that can be reaching for those patients, as I see, not so more difficult that are not in monotherapy. I use 2-3 weeks to reach for 200, and then 2 weeks, sorry, to reach 200, and then to move to higher dosage that can be needed in those patients. Next slide. And the third situation that we will talk about this later, I suggest to go slowly if the patient is taking concomitant sodium channel blockers. In this case, I suggest 50 milligrams increase up the dosage per week. But to answer again your question, monotherapy, you can reach protection from day one with 200 and can be tolerated for this patient. If you are concerned for whatever reason, 50-50 in 1 week, 100-100, that can be effective.
Thank you, Vicente. Luiz, o professor Villanova nos dá uma noção de poder ir um pouco rápido e até proteger o paciente quase que no primeiro dia, né? Na primeira semana com as doses. Qual é que tem sido a tua experiência de início da lacosamida? A gente sabe assim que cada paciente tem um organismo diferente, tem um grau de tolerabilidade distinta. Como é que tu vê essa questão? Porque essa experiência é muito importante que o professor nos dá, que dá uma tranquilidade de poder iniciar, às vezes, já com uma dose terapêutica de cara. Alguns pacientes tenho tido alguns efeitos colaterais quando eu inicio direto com 200 miligramas, ou mesmo com 100. Então, claro que cada um tem a sua experiência. Qual é a tua experiência quanto à forma de iniciar a lacosamida em monoterapia?
Eu acho que isso é um assunto extremamente importante, porque titulação, ela classicamente em epilepsia, a gente orienta e faz ela de forma lenta. Mas a lacosamida permite essa quebra de paradigma, que seria entrar com a dose terapêutica logo de cara, logo no primeiro dia, 100 miligramas 2 vezes ao dia. Em geral, eu sou bastante conservador, André, a gente já teve essa discussão outras vezes. Você geralmente é um pouco mais agressivo do que eu no tratamento dos pacientes com epilepsia. E eu, em geral, inicio de forma com doses menores, como o professor Villanueva sugeriu. Então, naquele paciente que a gente tem um feeling que tem menos tolerabilidade, ou, claro, utilizando bloqueadores de canal de sódio com potencial maior de efeito adverso de interação, costumo ir com doses menores. Naquele paciente, epilepsia de lobo temporal, atrofia de hipocampo, com descarga epileptiforme, já sabemos que costumam evoluir para uma refratariedade. Nesse caso, iniciamos com 100 miligramas 2 vezes. Não tem tido tanto problema, não, André. Eu acho
interessante isso. Eu tenho tido... como é que eu costumo fazer? Primeiro, eu costumo ter um histórico do paciente sobre qual a sensibilidade dele a medicações. A gente conhece os pacientes. Algumas pessoas já tiveram, por exemplo, em outros medicamentos, com maior frequência e mesmo com doses menores, mais efeitos colaterais. Nessas pessoas eu vou um pouco mais devagar. Se a pessoa tem um histórico de ter uma tolerabilidade boa, eu às vezes vou um pouco mais rápido. Eu tendo a iniciar 50 2 vezes. Deixando assim, eu acho que é interessante poder trocar essa experiência. Mas é muito importante que a gente saiba que aqueles pacientes que de repente começaram a ter bastante crise e a gente quer de uma vez chegar num nível terapêutico bom, é muito importante a experiência do Dr. Villanueva de que em muitos pacientes ele inicia com 100 2 vezes. Eu faço isso pouco, mas é muito reconfortante saber que eventualmente se pode fazer assim, em alguns casos que vai ser necessário para ter mais proteção. Veja bem, eu estou recebendo perguntas de vocês muito interessantes quase todas elas sobre o que vai vir de agora em diante, que é algumas coisas ligadas à politerapia. Quer dizer, como é que vai ser a associação da lacosamida, até que ponto, uma vez iniciada a lacosamida, em politerapia vai se poder trazer para monoterapia. Eu estou com tudo isso aqui e daqui a pouquinho eu vou fazer essas perguntas para o professor Villanueva. Eu só gostaria de colocar uma ou duas questões nesta linha para que ele se pronuncie e depois a gente vai entrar num debate junto com o que as pessoas estão nos perguntando. Vicente, now we will have a few questions regarding the practice, you see, your experience, your hands-on experience on how to do stuff with lacosamide. And people are asking exactly this. So I will not pose you the questions that people are sending, because I want you to go a little bit further into this issue of polytherapy. So the first thing I was going to ask you as a formal question, I think it will show up in the screen for you now. Can you go one slide more? You see, is that most studies, as in any, or I think there is one more or something, there's a question there. I think there's one more slide, I think, maybe. What I'll tell is the following. Most studies, and everybody that's listening to us now are aware of this. When these studies, the initial studies, the pivotal studies are performed, they are usually in polytherapy, meaning you have a new drug and you add with other drugs. And most people that are with us this evening throughout Brazil, they already have read so many papers of so many medications in which, well, it's one more drug that's added to 2 or 3 others and will give this or that result, and not very clearly what benefit that will bring. So bringing lacosamide into the center stage, this first question is an overall question, not a very practical, but an overall, your impression of how useful it is to add lacosamide to a scheme, to another drug that's already being used and is not controlling seizures. So, as a general impression, and later on we'll get into the specifics of this.
Okay, next slide, please. I think that we did this exercise in a study that, and I will tell you afterward my opinion. This study, we consider patients that had been tried with 1 or 2 medication before, just 1 or 2, and then we add lacosamide. Next slide, please. We got like 160 patients, and we observed that the rate or the possibility to get seizure-free was over 60% when the patient have tried 1 anti-seizure medication before, and over 35%, around 35% when they have tried 2 medication before. And these outcomes were very good, that probably much better than those that has been reported in other studies, like Brody study in the past with other medications. So this bring us the idea that this was a very strong medication that it deserved to use in the patient. And more than that, as I said in the first part, we were able to do this without having interactions, without having skin rashes, and we had skin rashes with any other sodium channel blocker from those that we had in the past. So that's what very important. And with these very good outcomes. Next slide, please. And also we will talk later about the combination. We observed that we were able to get patients seizure-free regardless of the combination. I mean, probably it was better, and this is rational polytherapy combined with a different mechanism of action. In this study, we observed that the outcomes on seizure-free was better with non-sodium channel blockers, combined with non-sodium channel blocker, but also with sodium channel blocker, we got a high percentage of patients that were seizure-free. Probably was a different type of sodium channel blocker than the ones that we had in the past. So that was the main reason that we were convinced about using this medication at the beginning in polytherapy, because it was highly effective to treat patients and have additional benefits that we have told before and probably later. But the first reason was efficacy and or effectiveness in patients already with other medication.
Vicente, before bringing Luis again into the debate, let me move quickly to another question on this, and then we open for the questions that are coming here many questions from the audience, okay? So exactly because you just mentioned that you may add, this slide that's now in the screen here, okay? You may add lacosamide either to another sodium channel blocker or to a non-sodium channel blocker. So give us your experience, your hands-on experience on how do you titrate lacosamide when you're adding it to another sodium channel blocker, let's say to adding to carbamazepine or to oxcarbazepine, for instance, versus how do you titrate when you're adding to a non-sodium channel blocker. So how is there a different way to titrate? And then after that, I'm here, have so many questions for you and for Luis. So get prepared.
Okay, no problem. Next slide, please. Next slide. So we have observed that it seems that also we can get patient seizure freedom with any combination. It's probably better, or we have very good outcomes, additional benefit when we combine with a non-sodium channel blocker. Next slide. Next slide, please. And we got more side effects than we combined with sodium channel blockers. Also, those that led to discontinuation was not so different, but we got more adverse event when we combined with a sodium channel blocker. So, to answer your question, next slide, please. When we combine with a non-sodium channel blocker, we do a faster titration, and we can increase up to 100 milligrams per week, and it's working, or the possibility of discontinuation is relatively low. But when we combine with a sodium channel blocker, I recommend to increase up the dosage in 50 milligrams per week. So half compared to a non-sodium channel blocker. But also it's very important to consider two more things. Next slide. First of all, to consider to reduce the dosage of the sodium channel blockers, particularly carbamazepine, oxcarbazepine, or lamotrigine. I'm not so aggressive as it's been claimed by some US studies, and I reduce around 30%, okay, when I combine. Sometimes you can withdraw the sodium channel blockers if you are considering that it's not useful, but if it's a refractory patient, you can combine. So increase up the dosage of lacosamide 50 milligrams per week, decrease progressively the dosage of the other sodium channel blocker, let's say about 1/3, but this is depending on the patient, of course, because every patient is totally different. And very important, and it's very useful in my own experience, to separate intakes. If you are taking carbamazepine or oxcarbazepine 2 times per day or 3 times per day, and you are starting lacosamide, if the patient have dizziness, that is the main side effects with this combination, what I did with good outcomes is to separate or lacosamide and, let's say, carbamazepine 1 hour. If the patients separate the intakes 1 hour, side effects also increase. Also decrease. So these three humble advices. First of all, slower titration, 50 milligrams per week. Second, decrease the dosage of other sodium channel blockers. And third, the separate intakes with other sodium channel blockers. Next slide. With non-sodium channel blockers, I don't care too much. I have not had issues with non-sodium channel blockers. Let's say Keppra or levetiracetam, or let's say topiramate or benzos or whatever. Just to consider when you are combining with valproic acid, if you are using high dosage of valproic acid, be careful with tremor, because if you increase up the dosage too much of lacosamide and you have a very high dosage of valproic acid, not with low dosage, but with high dosage, let's say over 2000 or so, you can have tremor. Otherwise, in my opinion, there is no much concern about this combination.
Thank you very much. Eu só
that's
gostaria de trazer, foi muito importante essa colocação, até queria te ouvir, Luiz, o seguinte, porque às vezes aparece uma ideia de que por ser um bloqueador de canal de sódio, a ideia é que não se associasse a outro bloqueador de canal de sódio. Eu tenho experiência de que vários pacientes com associação de lacosamida e outro bloqueador de canal de sódio têm um efeito anti-crises muito bom. Então, eu acho importante levar em conta esse cuidado, né, de ir mais devagar, às vezes reduzir a dose do outro bloqueador de canal de sódio, porque a gente sabe que senão aumenta risco assim, de tremor, de ataxia, de tontura, etc. Mas são associações que podem dar certo, né? Então, eu acho que é muito importante, porque às vezes corre uma ideia de não se poder fazer isso. Acho que pode fazer isso, e é muito importante a gente valorizar esses estudos do grupo do Dr. Villanueva, em que ele mostra como fazer com bloqueador de sódio e quando não é bloqueador de sódio. Como é que tu lidas com isso na prática, Luiz?
Bom, eu concordo, André. Eu acho que o professor Villanueva trouxe algumas informações de ordem prática bastante úteis, que são justamente essas de como lidar e como associar a lacosamida. E essa questão bastante interessante, né? Espaçar a tomada entre as medicações diferentes. Isso é bastante interessante. Realmente, usualmente, a gente evita utilizar medicações que tenham o mesmo mecanismo de ação. Mas eu acho que cabe destacar aqui que a lacosamida, então, teoricamente, tem um mecanismo de ação diferenciado, né? Que é esse bloqueio da fase lenta dos canais de sódio, diferente de todos os outros bloqueadores de canais de sódio. É claro que os efeitos relacionados, que são justamente, principalmente a sonolência, vertigem, náusea, relacionado ao bloqueio do canal de sódio, ele costuma ser dose dependente e vai ser mais frequente mesmo com os bloqueadores. Mas um ponto que eu acho que é bastante importante a gente lembrar para a audiência é justamente isso, né? Que após uma segunda monoterapia, usualmente o controle de crises, a chance de controle de crises cai bastante. Cai lá para baixo, lá para a taxa de 5%, ou talvez até menos. Mas talvez essa combinação com a lacosamida seja uma opção para esses pacientes com crises refratárias e de difícil controle.
So, Vicente, thank you, because this was exactly the spirit of this activity, okay? Having your experience in very practical points of how people will use the medication with safety and having behind the experience of someone with your background and our experience. So now let's turn to some questions that people are sending us, okay? And people are enjoying you, are congratulating you for your for the activity, okay? So I think that it's a very important question from my colleague Osvaldo Couto Jr. And he asks you, if you were to choose one other of the other 16 or 17 anti-seizure medications, what your preferred polytherapy with lacosamide? Is lacosamide plus what? What is the champion to associate with lacosamide? Your experience.
Okay. As I said, you can combine with anything, but if I will say what will be number one will be lacosamide plus levetiracetam or brivaracetam.
Okay, so that's your...
SV2A, an SV2A medicine plus sodium channel blocker.
Perfect.
But as I say, you can combine with anything.
Okay, so then he asks, he wanted to have your question, your answer. You just mentioned this, so it's levetiracetam. We don't have in Brazil brivaracetam yet. Okay, so
levetiracetam.
Okay, and then he asks you this. Okay, and then you control the seizures. How would you transform this dual therapy into a monotherapy with lacosamide? Do you increase doses of lacosamide? How fast you decrease the other medication? Do you feel that you should do this, or if you succeed in getting seizure controlled, you just relax and say, I won't do anything else because now I've got seizures under control? So he wants to know, after you add lacosamide to levetiracetam, which is your preferred drug, and you control the seizures, when do you decide to take out levetiracetam and believe that lacosamide will be the only medication that will control the seizures, now as a transformation into monotherapy, and when you do not do this? And how do you do this in practice?
Okay. I have to confess that I'm a conservative person. So if I have had issues to have my patient under control, and I get then seizure free, I'm not in a hurry to have monotherapy. I have many patients, in fact, with a medium dosage of lacosamide plus levetiracetam, and if they are doing well, I'm not, a super fan of moving to monotherapy. But if for some reason, and I have many patients, and I do conversion to monotherapy for some of them, if I have to do it, if the patient have been done well with 200 milligrams lacosamide, that is the case in many cases, I try to decrease, and I want to go to monotherapy. I don't use to increase up the dosage if it's being well with 200 milligrams, and I decrease the dosage of levetiracetam quite slowly. I will say like 500 milligrams, every 3 months or something like that, not faster. And for me to be convinced that it's working, I need at least to be 6 months seizure-free, okay? If I don't have the security that after adding lacosamide to a patient that was taking levetiracetam, it's been seizure-free for 6 months, I don't use to reduce the dosage of levetiracetam, unless the patient was having side effects like irritability or whatever. In this case, it's a different situation. But otherwise, I will be quite slow, careful, and if I decide to reduce and go to monotherapy, wait at least for 6 months.
Luiz, o que tu faz assim? Vamos dizer, o desejo de todo neurologista, todo paciente, todo familiar é usar o mínimo de remédio e ter o máximo de efeito. Aí tu entrasse com a lacosamida e controlasse as crises. Tu tira o outro?
Eu tô com o professor Vicente, eu sou mais conservador também. Em geral, não retiro de imediato, concordo com ele, pelo menos uns 6 meses ou às vezes até mais, para tentar mexer na outra medicação. Mas não temos uma resposta para isso, né, André? Eu acho que não existe na literatura um estudo específico que possa embasar essa decisão.
Perfect. People are sending questions in capital letters, So I think I'm urged to ask a few questions that are being asked in capital letters. And when it's in capital letters, don't forget to ask him if can we use it in women of childbearing age. I mean, how safe it is over gestation. So people can get calm. I'm asking the question.
Okay, so there are two situations that we consider in women with childbearing potential. First of all, the use of oral contraception, and this drug is perfect in a patient that using oral contraception because have no interaction. So probably it will be the sodium channel blockers, probably even better than lamotrigine, because as you know, oral pills can decrease the levels of lamotrigine. So I will say that it's the sodium channel blocker cleaner in a patient that is taking oral contraception. Regarding pregnancy, that is the burning question. Pregnancy, here I can answer in 2 ways. First of all, the conservative answer will be to go to the registry. In the international registries, there are not many patients with lacosamide because this is a newer medication, and most of the results of the Europe or the American registry are still not providing data with lacosamide. My own experience in patient with monotherapy lacosamide, I have had pregnancies and I have not issues. What I do is the patient is doing well with lacosamide, and you can get a lacosamide monotherapy, and you have problems with other type of combination, I used to keep the patient with lacosamide for pregnancy. Okay, and in a women with childbearing potential, I use lacosamide I think is the best option because even though I need for some reason to switch to other medication when she want to get pregnant, that is not the case for all my lacosamide patients, because as I say, I have had pregnancies with monotherapy lacosamide, you can do it. And it's clean regarding oral contraception. So to summarize, in pregnancy, not enough information from the registries, own experience is monotherapy is good.
I have to make a question for both of you, because that's a very Brazilian thing. Oftentimes, in outpatient clinics, in hospitals, or in offices of neurologists, comes a patient's focal seizures who had been seen elsewhere and has been prescribed phenobarbital, okay? We know that phenobarbital has a few aspects. Sometimes it's effective for a while, and then for some mechanisms of tolerance or things like this, it starts to diminish the efficacy. But on the other hand, everybody knows, and the person who posed the question clearly knows, that it's one of the medications that are more, that the brain becomes more, quote unquote, addicted to. In other words, when you start diminishing phenobarbital, very often people have breakthrough seizures, okay? Then what most epileptologists do, most neurologists do, is to add another medication that you want to use instead of phenobarbital because it's not being effective. So you see, the expression is bad with not working, but also very dangerous to stop. So that's the situation. Then you add a second medication, and the second medication was lacosamide, okay? Then lacosamide was added because it was focal seizures. We went to like 400 milligrams, and then seizures are controlled. How safe are you, okay? How, I mean, that you can start diminishing and withdrawing phenobarbital after getting seizures controlled with the addition of lacosamide? That's the question.
Okay. So I have to confess that I'm always afraid about phenobarbital, to discontinue phenobarbital, because it's the most dangerous medication to discontinue. So in this case, I am quite conservative when I decrease phenobarbital. I try to protect, in this particular situation, I protect more my patient, different from the case of levetiracetam, because of this, let's say, withdrawn seizures, sometimes just because of the discontinuation of the medication. I will try to keep at least 300 milligrams of lacosamide, and my policy is to discontinue 25 milligrams phenobarbital every 2 months, not faster. And then probably you can be successful. That will be what I will do. We don't have too many patients with phenobarb in Spain, but I still have a few.
Diferente da Espanha, aqui no Brasil nós temos muitos pacientes que chegam no serviço público utilizando o fenobarbital e muitas vezes utilizando o fenobarbital já em politerapia com outras medicações. O ideal seria tentar realmente a retirada do fenobarbital, por ser uma medicação indutora, a longo prazo pode trazer os problemas relacionados aos indutores, e geralmente é o que você comentou, André. Geralmente ela perde eficácia e o indivíduo continua tendo crises. Mas o problema é que o fenobarbital ele é bastante difícil de ser retirado. O que o professor Villanueva colocou é o que eu costumo fazer também. Geralmente a retirada de 25 miligramas pelo menos por mês, a cada mês. E não é incomum do paciente voltar, e não só com uma crise. Muitas vezes ele tem uma crise generalizada que há muitos anos ele não tinha essa crise generalizada. Nessa condição, quando acontece uma vez, eu deixo o fenobarbital quieto, deixo a medicação por ali mesmo e eventualmente tento anos após.
Eu tenho uma experiência que é muito parecida, mas eu tenho alguns pacientes em que eu tive esses breakthrough seizures, como se chama, essas crises que vêm assim, mas como a pessoa foi se sentindo muito melhor sem o fenobarbital, a impressão que eu tenho é que se mantém. Claro, eu lentifico mais a retirada. Em vez de fazer mês a mês, eu passo 3 em 3 meses. Eu até volto um pouquinho para uma dose um pouco maior, espero aí 3 em 3 meses, mas às vezes assim, dá uma crise, dá outra e depois não dá mais, entendeu? E se consegue. Então, claro que é uma questão de riscos e benefícios. Vicente, as I expected, I'm in a really bad situation here because we have an organization of our discussion, but people are sending questions all the time. So I'm really trying to balance these two situations. But I will ask people to wait for a second because the next question I think is very important and very practical. So, and after you answer this next question, then we come to another round of questions from the audience, okay? And this question is a very practical one. You decided, Luis decided, I decided to start the treatment of a patient's focal onset seizures with monotherapy with lacosamide. And then we go up to 400 milligrams a day, which is more or less the usual dosage that you go in an adult, for instance, okay? The usual dosage. And then after a few months, the patient has seizures again. And then you have, but he's like tolerating well lacosamide, everything is okay, but still have some seizures. And then you decide you're gonna do something. And this something, in my mind, can be one of 4 things. You can either increase lacosamide for some patients going up to 600 milligrams a day. You can add another sodium channel blocker in medium dosages. You can add a non-sodium channel blocker, for instance, valproic acid or topiramate. Or you can add, as very often we do, a benzodiazepine. In Brazil, we use very often clobazam. So your experience, of course, every patient is a patient. You have to take into consideration the type of epilepsy, the etiology, and so on. But in general, which of these 4 options you believe would be your preferred option for a patient's focal onset seizures who started on lacosamide, was okay for a while, has some other seizures, and you have to do something else?
Okay, so let's go back to slides.
Go back to slides. Yeah.
Okay, next slide, please. Okay, next slide, please. Okay, my answer is any possibility from those that you mentioned can be possible. Okay, so probably you will have patients that you can choose any of the possibilities you mentioned. But if I will say what will be number 1 for me, will be to combine with a non-sodium channel blocker. This is the list in one of our study of the best combination. As you see, the best combination was lacosamide plus levetiracetam, lacosamide plus valproic acid, but also with sodium channel blocker like lamotrigine. That was the 3rd possibility. So next slide. And other studies have some similar outcomes. Valproic, levetiracetam, topiramate, non-sodium channel blocker, but also some sodium channel blocker like lamotrigine. So if I would have to say, first, from those that you give me, I will say there are patients for anything, for any possibility. But number 1 for me will be to combine with a non-sodium channel blocker. From those, my first option will be levetiracetam. But also valproic acid or topiramate could be possible, as you see in those studies, and also another sodium channel blocker. Because as you mentioned before, this is a different mechanism of action within sodium channel blockers, and you can use it. Clobazam is a good option. We can use also clobazam in some patients, but will be my first option. And to increase over 400, yeah, I used to do it, but not so frequent in monotherapy. I do it more frequently in polytherapy, probably because in those difficult to treat patients, I have seen this chance to have better control with dosage over 400. With monotherapy, I will pick one of the options that I mentioned before.
Okay. Now I have two questions which are very, sort of less, more or less related regarding one is the interaction with anticoagulants, okay? So can anticoagulants interfere with serum levels of lacosamide, or on the other hand, can lacosamide interfere with the serum levels of the new oral anticoagulants, the DOACs, okay? Like the new anticoagulants. What's your expression, your experience with this?
I think this is clear. No interaction. This is the best advantage of this medication, as I say at the beginning of my presentation, with or compare with other sodium channel blockers. That is the lack of interaction. There are very nice studies that were done by the company with warfarin, an old anticoagulant, and there were no interaction, no relevant interaction. So this is the main advantage to use it in those patients. With the new anticoagulants, there are no studies, but with the pharmacokinetics of this medication, we assume that there are no interaction because there are not with any other medication. So I will say that if I have a patient with anticoagulants, I try to use clean medication, and one of those, and number one, when I think in a sodium channel blocker, will be lacosamide.
So before bringing you into the discussion, there is a very, very intelligent question here. As we know, in people, in elderly people with some cardiopathy, okay, we have to be very careful about sodium channel blockers. We know that carbamazepine, lamotrigine, phenytoin can have can lead to heart problems in cardiac problems in people with cardiologic problems. Okay, so how does lacosamide fare with this? I mean, in people with cardiopathy, particularly in elderly people with cardiopathy, can you use lacosamide safely?
Okay, very interesting question. Yeah, it's true. I will say my experience, we have published more than 1,000 patients, or probably close to 2,000 patients in different studies. And with oral lacosamide, we have no heart problem in our series. So there are no cardiac problem in our experience. Of course, you can't use this medication with a patient with a second atrioventricular block. This is clear. You can use it. But other than that, it's a safe medication. We just have one patient with atrioventricular block with the intravenous formulation, intravenous with a shot, in one patient that was taking a beta blocker and a calcium antagonist together with lacosamide. So these two types of drugs. But other than in this particular medication, combination, and other, when using IV lacosamide with oral formulation, we have not had issues. So I don't do an electrocardiogram in a patient that I start lacosamide, or I use the same policy that with any other medication. All the patients with epilepsy should have an electrocardiogram at the moment of diagnosis, etc. So if you have this patient with a second atrioventricular block, I'm not using lacosamide. But other than that, I think it's safe.
Perfect. Now it's for you and for betting. Can you have some level of some use of alcohol with lacosamide? For the two of you.
Please, Luis.
Bom, em geral, eu sei que isso é controverso, mas em geral eu oriento os pacientes para evitarem o uso de bebida alcoólica, todos eles que têm epilepsia. Como médico, a gente sempre procura orientar os hábitos saudáveis e eu sempre oriento a evitar o uso de bebida alcoólica. Mas eu acho que para um indivíduo que já tem tantas privações, o indivíduo tem epilepsia, não pode dirigir, tem que tomar a medicação diariamente, fazer exames periódicos, em doses, em baixas doses, quando o indivíduo tem e faz questão, eu, em geral, oriento que tudo bem, que pode.
How is it in Spain, Vicente? The question of alcohol use and epilepsy.
I will say different situations. When I start or when I diagnose a patient and when I start treatment, any medication, not particularly with lacosamide, any medication, I don't recommend to I say to my patient not to take alcohol, okay, at the beginning. I think that we need a period to have everything under control and so on. If the patient is doing well, is well controlled, you know, in this case, situation can be different, and I accept a low quantity of alcohol per day, you know, a glass of or a cup of wine during dinner or during lunch, or a beer when go out, but always in a moderate way. I think that we should be very careful with adolescents, because when you say you can drink something, they say that, or they understand that they can drink everything. So, you know, I'm careful, but if the patient is under control, I agree with Luis that you should be, you know, you should understand that the life can be difficult for them, and to drink a low quantity of alcohol can be acceptable.
Okay. So let me organize things, okay? We have one question that both came from the audience and we had already prepared to discuss with you. And then I will pose for you guys 2 or 3 more questions coming from the audience over in general, in miscellaneous questions on lacosamide. And then I will ask you to give a final message to our Brazilian neurologists, okay? So the question that came both from the audience, and we had already discussed this, is the issue of the use of lacosamide in children, okay? Although it's not officially authorized in label, the off-label use is more and more common in Brazil, and I personally use very often in kids, and I'm having very good results, okay? Usually go until 200 at most, but usually very good results in general. How is it in Spain? What's your experience? If you don't see kids, how your neuropediatrician colleagues have, what have they think about the use of lacosamide in kids?
Okay, so next slide, please, again. Next slide, next slide, next. I will bring you this study. Probably not big, it's not the best study in the world at all, but it's a study that was published 13 years ago. Sorry, 11 years ago. So long time ago. And at this moment, our center, together with other centers in Spain, published this series of patients that at the beginning we were already using this medication. And after this, we have moved and we use this medication frequently. In fact, it's approved in Europe from the age of 2. Not only in focal, also in generalized tonic-clonic seizures. And we use this medication frequently. I see patients in my children in my private practice, and I use very frequently. And is quite highly effective and well tolerated, and it happened in the adults. The dosage we start with 1 milligram per kilo a day, and we increase up to 4, 8, even 12 milligrams per kilo, depending on the patient. Yeah, it's widely used, and is a medication that is not a new medication, as you can see here, after many years using this medication. And one more slide, next slide. Next slide, please. As you see, side effects are similar than in adults. Next slide. And something very interesting in the pediatric population, this been already also is not approved. There are studies in some patients with Lennox-Gastaut all the studies too, and it can be useful because these patients have a lot of seizure and can be useful for some focal seizure. And don't forget, this drug has a clinical trial and has approval in generalized tonic-clonic seizure. So I think that for pediatrics, that is been used for many years in Spain and is quite useful and useful for different type of seizures.
Tu usas em criança, Luiz?
Não tenho experiência.
Eu tenho usado bastante. Now, there are 3 questions, and then we'll have your final word for the Brazilian neurologists. One question was actually for both of you. Now, miscellaneous questions, okay? This is a very practical thing. I mean, you've discussed, and Luis as well, you have discussed that how do you titrate the dosage, and you go up to 200 or 300 or 400. But the person here wants to know, our colleague, in your experience, how often you control seizures with 200, how often you control with 300, how often you have to go up to 400. So the question is, more specifically, is it feasible in an adult to go up to 200 and just wait? And how often do you have to go over that, or that will be enough for many, many patients? So that's a very practical, a very important question. Thank you for having sent us this question.
Okay, monotherapy, most patient 200. Clear. Start new monotherapy. In our experience, in the clinical trials, in everything, many patients will be to 200. So my first step in monotherapy is 200. If there are seizures, I increase up the dosage. Polytherapy, drug resistant, most of them 300 or 400, most of them. In very drug resistant or highly drug resistant, 400 in most of them.
Luiz.
Eu concordo com o professor Villanueva e eu acho que isso reflete aquele conhecimento geral que 60%, 70% dos indivíduos com epilepsia têm crises de fácil controle, né? Tem um viés do centro de referência, do centro universitário, então a gente está acostumado a tratar os pacientes de difícil controle, que geralmente precisam de doses maiores, ou até mesmo das associações e, finalmente, outros tipos de tratamento. Eu diria que até costumo utilizar até doses menores, André. Até 50 miligramas 2 vezes ao dia, eu sei que é considerado subdose, mas muitos pacientes controlam até com uma dose menor do que os 200 miligramas ao dia que o professor Villanueva colocou.
A grande questão, I think it's a very important, it's a very important message. So, I'll go with this in Portuguese, maybe easier for me. Em geral, eu acho que isso é importante colocar para todos os colegas. Eu acho que é assim, talvez todo mundo concorde ou quem não concorda, manda alguma coisa aqui para a gente. Porque, em geral, a gente tem que ter a gente mira num determinado patamar. Assim, eu começo a medicação e eu tenho uma ideia que eu vou até onde. Então, ali é a primeira parada, a primeira escala, né? Essa primeira escala, essa é a pergunta. Se essa primeira parada é em 200 ou é mais do que 200, a resposta foi objetiva de vocês dois, em 200. E, a partir daí, bom, se dá crise, se aumenta, muito claro se é uma situação de refratariedade, se vai um pouco mais. Eu tenho também essa noção, e agora, por outro lado, eu tenho também um desejo, né, de que seja, eu vou colocar isso em inglês, I have a wish that we could move forward in terms of studies of specific pathologies behind epileptic diseases. For instance, we don't know if the person has hippocampal sclerosis, whether it's valid to go only up to 200 or directly up to a higher dosage. You know what I mean? We don't know if you have cortical dysplasia, if that would change. So there are some things in anti-seizure medication treatment, in the science of this, that is still lacking, okay? Because most studies, they pull together patients, different etiologies, different duration of epilepsies, different frequency of seizures before you start the medication, and all this impact a little bit. I tend to go more than 200 in the first, okay, if the patient has hippocampal sclerosis or cortical dysplasia, or have, you see, in this situation, starting treatment with this. So, but that's a personal thing. So I think it's important that our colleagues know that it's okay to go up to 200 and then go up. It's not bad if you already anticipate that it's going to be very difficult to control, that you can go directly to, like, say, to 300 or 400. The other question here, which I think is very important, and I mean, you already mentioned, and I think that our colleague clearly understands this, but he wants to go a little bit in depth in the issue of teratogenicity and in the issue of adverse effects in the fetus, okay, over in the development of the child if the fetus or embryo is exposed to lacosamide. And this colleague of ours has mentioned some experimental studies in mice, okay, in which the offspring of mice whose mother, the offspring of mice mothers who had lacosamide had some abnormalities in terms of development, something akin to valproic acid, the valproic acid issue of abnormalities in development after the first years of life, and also some psychiatric disturbance. What do you make of these experimental studies at this point? For instance, these mothers, these women that you have been treating, and who have had successful gestations, do you know if their offspring, their children had some problems in terms of development or psychiatric disturbance, let's say ADHD or things like this?
No. I remember a young teacher that I saw probably a couple of weeks ago. She got pregnant a few years. Her kid probably had 7 years or so, or 8 years maybe. Time flies, and is doing very well. Is doing perfect. No problems. This come to my mind. As I say, we don't have enough information, or we don't have as much information as we have, like with levetiracetam, with lamotrigine, or with other medication, where there are follow-up of children after birth. But if I consider that this patient, and this was the case of this teacher, this young teacher that I mentioned before, that was doing well with this medication, I try to go to monotherapy and I use it. If I want to be 100% conservative, or let's say not to have anything or not to risk anything, and my only concern was to avoid potential malformation, then go to lamotrigine or levetiracetam. That are the two medications that the registry are not proving having problems, not only during pregnancy or with malformation, but with the follow-up. But in my experience, I have not seen these psychiatric problems.
Luiz.
Eu acho que esses estudos, é importante notar que esses estudos em animais experimentais, eles utilizam uma dose bastante alta da medicação, uma dose que usualmente a gente não utiliza na prática clínica. Então, eu não conheço, eu não sei que estudo especificamente esse que ele mencionou, acho que o assunto é importante e permanece em investigação. Mas isso é bastante importante lembrar. Geralmente a dose é muito mais elevada do que a gente utiliza na prática clínica. E aí é um paralelo com o que acontece no valproato. A gente sabe também que o valproato, a chance, a teratogenicidade dele é claramente dose dependente. Quanto maior a dosagem, maior a incidência de malformações.
Two last practical questions, okay? One, the unavoidable question about the association with cannabidiol. Do you have this experience?
Yes, I have at least 1 or 2 patients that have combined with cannabidiol, and also we have, I don't know if it is the same that you have in Brazil. We have Epidiolex. We
don't have Epidiolex, but we have similar ones.
You have artisan cannabidiol. So as we have seen many interaction with cannabidiol because it's not very clean drug, and we have some interaction, but there are no interaction with lacosamide. So I will say it's safe. I will just concern about the main side effects or some of the side effects as can be, at least with the Epidiolex, that the one that we have in Europe, like somnolence or fatigue or so that can be seen in some patients with cannabidiol. But the main concern for me with cannabidiol is liver enzyme increase. And it's nearly impossible to see liver enzyme increase when you combine with lacosamide. So I will say it can be so, but of course, wouldn't be my favorite combination. And the reason is that we have cannabidiol approved in Lennox-Gastaut and Dravet syndrome in Europe, and TSC, tuberous sclerosis. So for the first two indications, at least for Dravet, I will try to avoid sodium channel blocker. So wouldn't be a good combination. But in terms of pharmacokinetics, it's fine.
Of course, the question was posed because in Brazil, at least, cannabidiol is being used for all sorts of epilepsies, and people use this. That's why there was this curiosity regarding your experience. Do you have something, experience with this? No? Okay. Now, the other question is very practical. It's about safety of lacosamide concerning the risk of Stevens-Johnson syndrome. So you mentioned that you have published or have read the publication of more than 1,000 patients. Have you seen Stevens-Johnson with lacosamide?
No, it's clear. No, I have not seen, and there are no reports, as far as I know, with Stevens-Johnson, or is not hardly described. So is the sodium channel blocker with less skin problems. Okay. It is clear.
Even when you increase rapidly, like starting with 100 times a day, twice a day, it's okay.
We use the IV formulation for many patients that we need to start with an infusion. We start with 406 milligrams in infusion. I have not seen a Stevens-Johnson in my life with this medication.
Now, the last question, okay? And this question is actually an invitation for you to give us a message to us neurologists in Brazil that are now more and more using lacosamide. At least I very often discuss this with colleagues and also with patients. I don't know, what do you think of this? That usually we need to be very confident when we prescribe an anti-seizure medication. I mean, a seizure is such a it's such a dreadful situation, okay? That you want to be as sure as possible that following your prescription, a seizure will not occur. Of course, that's what we all desire with any medication. So we tend to use more medications that we are more used to use over the years. Lacosamide is, for us in Brazil, a relatively new drug, in which, of course, people have less experience than with other drugs that we have 30 years of experience. So what's your message for Brazilian neurologists in terms of how confident a neurologist can be to prescribe lacosamide to really avoid the seizures in patients with new onset epilepsy, for instance?
Okay, I will finish with some of my slides just to illustrate. Can we go back to the slides? Next. 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 So that will be the first message that I would like to convey. How confident? Take a look of side effects. If you take a look of this review of side effects, the possibility of side effects with lacosamide is much lower with most of the other drugs. So when I start to use a new drug, the first thing is to use something that was safe, that didn't make a trouble to my patient. So, okay, so this will be the first thing. Next slide. Next slide. And we have seen that there are no problems regarding mood, regarding psychiatric issues. There are different studies. Next slide. Next slide. In terms of cognition, we have already seen, next slide, please. This is for mood disorder. In terms of cognition, there are good outcomes. This is a study that it's better than carbamazepine. Next slide. It's similar to lamotrigine, much better than topiramate. Next slide. Next slide. And there are several studies that prove that after switching any other sodium channel blocker, like in this study in Korea, the patient had good outcomes in terms of seizure control, in terms of using a cleaner drug, and in terms of having less side effects. So to conclude, I will say that if I start a new medication, I want something that was easy to use. We have said that this drug can be titrated in 1 week or even day one. Second, that was clean in order to combine with other medication. We have seen that this is the case. Third, few side effects and good in terms of cognition, in terms of rashes, in terms of different situations, as we mentioned. Number 4. And number 5, effective. We have seen that it's effective in different studies, as we presented here, in patients with monotherapy and in patients with drug-resistant epilepsy. So all this make this a suitable drug. And if I had to start with this medication, I will feel safe that it's not frequent that this drug is going to make a trouble to my patient. That will be my final words.
Very nice final words, but stay with us. Luiz.
Of course, of course.
Bom, eu
Últimas palavras.
também concordo aí com o professor Villanueva e reforço as palavras dele. Lacosamida, medicação eficaz para monoterapia e politerapia para indivíduos com epilepsia focal. Nós queremos um remédio que seja eficaz, com baixo perfil de efeitos adversos, que é o caso da lacosamida, e também uma medicação fácil de usar. Ela já pode ser utilizada em dose terapêutica desde o primeiro dia e, quando necessário, a titulação é bastante fácil, não é? Então, uma medicação fácil e sem interações medicamentosas, sem preocupação se ela vai afetar o nível sérico de outra medicação. Portanto, um remédio fácil de usar e ótimo para a prática clínica. Eu acho que ela, voltando àquele equilíbrio entre tolerabilidade e controle de crises, é uma medicação com perfil bem próximo do ideal.
Ok. Pessoal, muito obrigado aí em primeiro lugar pela Libs, pela confiança que colocou na gente de poder fazer esse debate e trazer essa atividade aí, né? A gente sabe que tem gente de bastante lugares do Brasil com a gente hoje. Eu acho que o pessoal gostou no sentido de a gente ter conseguido lidar em termos práticos com coisas do dia a dia da prescrição. Thank you, Vicente, for having grasped the idea we had, which was to really have your experience in dealing with very practical day-to-day issues regarding the treatment of epilepsy, and particularly the use of lacosamide. So I think people enjoyed very much this, because this is not something of a theoretical thing. It was like how you do in practice. That's exactly what we wanted to do. So thank you very much for having been with us this evening, and hopefully you have time to, in the future, to have other opportunities to discuss these issues as knowledge advances in terms of the use of lacosamide. Thank you very much.
Thank you.
Então, pessoal, boa noite, né? Eu acho que a gente já até passou um pouquinho do tempo. E bom jantar para todo mundo aí que está pelos restaurantes do Brasil. Um abraço. Obrigado, Luiz. Acho que foi super legal.
A epilepsia é uma experiência que tira o paciente do eixo, limitando atividades simples como dirigir, viajar sozinho ou até mesmo nadar. E o tratamento que era para ser um alívio, muitas vezes traz outros sofrimentos. E assim o paciente perde o controle da vida, ora temeroso que uma nova crise possa acontecer, ora refém de medicamentos que o limitam pelos efeitos indesejados. Lacos chegou para dar mais controle à vida dos pacientes. Pois lacosamida é tranquilidade de prescrição com boa tolerabilidade. É segurança do baixo perfil e interações medicamentosas para uma qualidade de vida melhor. Assim, sem provocar mais complicações, abraça vários perfis de pacientes. Lacos acredita que falar sobre qualidade de vida de um paciente com epilepsia é olhar além das crises epiléticas, é transformar o medo em liberdade, é entender que se quer viver com controle da própria vida, sem medos, sem complicações adicionais. Lacos, controle além das crises.